I will talk today about the dose and timing of continuous renal replacement therapy according to precision medicine. So I will start with the timing of renal replacement therapy, and in the second part of my talk I will talk about the dose of renal replacement therapy. So the question is, when should we start renal replacement therapy? In 2012, the KDIGO guidelines were published, and we find two recommendations regarding the initiation of renal replacement therapy. The first recommendation says, initiate renal replacement therapy emergently when life-threatening changes in fluid, electrolyte, and acid-base balance exist. I think nobody in the audience would argue against this statement. If there is a life-threatening situation, we should start immediately. However, if a patient has a progressive decline of kidney function, a situation which probably occurs more often in the ICU, we can read the following recommendation. Consider the broader clinical context, the presence of conditions that can be modified with renal replacement therapy, and trends of laboratory tests rather than single blood urea nitrogen and creatinine thresholds alone when making the decision to start renal replacement therapy. This is a really weak statement, and it doesn't help us with the decision when to start renal replacement therapy. This is a meta-analysis which was published back in 2011, and this meta-analysis included 15 studies, surgical as well as non-surgical patients, and the primary outcome was a 20-day all-cause mortality. And this study demonstrated that early initiation of renal replacement therapy is associated with a better outcome. So the odds ratio was 0.446. However, no conclusions can be drawn from this study because the study had several limitations, including the high heterogeneity of the included studies. So the timing of renal replacement therapy is still a puzzle. There is a risk of harm from unnecessary delay because patients with an acute kidney injury can develop complications, for example, hypervolemia, and it is known that this is associated with an increased mortality. However, on the other side, there is also a risk of unnecessary treatment because there are patients who can spontaneously recover from acute kidney injury without requiring renal replacement therapy. In fact, it's really hard to predict which patient will ultimately require renal replacement therapy. And this study investigated patients with AKI who required renal replacement therapy and not, and demonstrated that for the most factors they investigated, there is no clear advantage for providing renal replacement therapy in elective cases of AKI. There was only one exception, and this was severe solute imbalance, as you can see here, creatinine above 4.2. Unfortunately, the authors didn't investigate urine output and volume overload. This study clearly demonstrates that it's really hard to identify the patients who are likely to benefit most from renal replacement therapy. We wanted to know whether the early or delayed initiation of renal replacement therapy in critically ill patients with acute kidney injury is associated with a better outcome. And this is the ELAINE trial. We performed this trial in Münster, in Germany. This is a prospective randomized trial. We included surgical as well as non-surgical patients. The primary outcome was a 90-day all-cause mortality. Secondary endpoints were duration of ICU and hospital stay, duration of renal replacement therapy, renal recovery, and 1 year all-cause mortality. And here on the right side, you see the study flow. So we screened all patients admitted to the ICU for moderate acute kidney injury according to stage 2. And when the patients met the following inclusion criteria, they were randomized at least one of the following conditions: severe sepsis, high doses of catecholamines, fluid overload or worsening of Horowitz index below 300 millimeter of mercury, non-renal SOFA score above 2, age between 18 and 90 years and plasma NGAL levels above 150 nanogram per mil. Then they were randomized into an early group. Here, renal replacement therapy was started within 8 hours after diagnosing a moderate acute kidney injury, and into a late group. Here, we waited until the patients developed a severe acute kidney injury, and then renal replacement therapy was started within the next 24 hours. The primary outcome was a 90-day all-cause mortality, and in this study we demonstrated that the early initiation of renal replacement therapy in critically ill patients with acute kidney injury significantly reduced the 90-day all-cause mortality, as you can see here, compared to the delayed group. We also looked for secondary outcomes, the 60-day all-cause mortality here. We were able to show that less patients died in the early group compared to the delayed group. This was not significant, but there was a clear trend. The duration of renal replacement therapy was significantly reduced in the early group compared to the delayed group, and the recovery of renal function at day 90 was significantly better in the early group compared to the delayed group, but there was no difference regarding the ICU stay between both groups. So we followed up the patient for 1 year, and then we looked for the composite endpoint, major adverse kidney events. This is a composite endpoint consisting of death, dialysis-dependent and persistent renal dysfunction, and we showed that less patients in the early group met this composite endpoint compared to the late group, 72 patients versus 106. And this was significant. We also looked for the mortality, and this was also significantly reduced in the early group compared to the late group after 1 year. At the same time, another study was published in the New England Journal of Medicine, and the authors investigated 2 initiation strategies for renal replacement therapy in critically ill patients. And this was the AKIKI trial. The authors included patients with a severe acute kidney injury who were on mechanical ventilation or vasopressors, and they excluded patients with life-threatening indications for dialysis on enrollment. In the early group, the patient received renal replacement therapy immediately, and in the late group, the authors waited until the patient developed an absolute indication for renal replacement therapy. That means development of severe hyperkalemia, metabolic acidosis, pulmonary edema, blood urea nitrogen above 112, or oliguria for more than 72 hours. This is a multi-center trial, and they recruited 620 patients. And here you see the primary outcomes, the 60-day all-cause mortality. There was no difference between the early and the late group, 48% versus 49%. However, if you look at the true data, you realize that only 51% of the patients in the delayed group were treated with renal replacement therapy. That means that 49% of all patients spontaneously recovered from acute kidney injury without requiring renal replacement therapy. But if we look or analyze the patient who really received renal replacement therapy, we see that the mortality, the 60-day mortality in the late group was higher compared to the early group, 62 versus 49. And this is exactly the same pattern we saw in our ELAINE trial. And I think the data are not so surprising because it is known that the complications are associated with an increased mortality. For example, hypervolemia. This was already shown back in 2009 by Bouchard and colleagues. They demonstrated that in fluid accumulation at the time of initiation of renal replacement therapy is associated with an increased mortality. However, we cannot compare the ELAINE trial with the AKIKI trial because 2 different patient populations were investigated. Beginning on the left, the early arm of the ELAINE trial recruited a lot of very sick patients and excluded patients with an emergent indications. And the late arm of the Lane trial recruited some patients who spontaneously recovered from acute kidney injury and some patients with emergent indication, but a lot of very sick patients. In contrast to this, the early arm of the AKIKI trial excluded patients who spontaneously recovered from AKI, and they included only a couple of very sick patients. And the late arm of the AKIKI trial, they recruited a lot of patients who spontaneously recovered from acute kidney injury, and they only recruited a couple of very sick patients and patients with emergent indication. So this year, Sean Bagshaw published a meta-analysis, and this meta-analysis demonstrates that the early initiation of renal replacement therapy is associated with a better outcome. However, this study has a problem because the definition of early is not unified. So that means the AKIKI trial used a severe AKI as an early starting point, whereas in the Lane trials, the severe AKI was used as a late time point. So we compare here apples with pears. So last year, the ADGI group published a new conceptual model for initiation of renal replacement therapy. And this is a patient-centered rather than a timing-centered approach. Beginning on the left, you see the demand for renal function. This consists of chronic disease burden, acute illness, volume load, and solid load. In the next column, you see the renal capacity. A shows a normal kidney, C a chronic kidney disease, and B is a kidney with a normal GFR, but a reduced renal capacity. And on the right side of the slide, you see how a demand-capacity imbalance can occur. So the capacity can go down, whereas the demand increases. Of course, just because a capacity demand imbalance occurs doesn't mean that we have to start renal replacement therapy. Other factors also have to be considered, and they are listed in this table. For example, severity of illness, necessity of the procedure, risks associated with the procedure, futility, and other considerations. So once we have decided that we start renal replacement therapy, we have to pick a dose. And the dose in renal replacement therapy is defined as the extracorporeal elimination of representative marker solute. So we have biochemical as well as clinical parameters. Biochemical parameters are small solute, correction of electrolyte disturbance, and clinical parameters are fluid balance and cardiovascular stability. The CRRT dose is equal to urea clearance, and this is equal to weight-based effluent flow rate. This is a landmark study which was published back in 2000 by Claudio Ronco, and in this study, the authors investigated the impact of the CRRT dose on mortality, and they demonstrated that patients who were treated with a low dose, 20 mL per kilogram per hour, had the highest mortality, and patients who were treated with a higher dose had a lower mortality. And this study was confirmed by another study which was published 2 years later, and they compared a high dose versus a standard CRRT dose. And here in this study, they used hemodialysis. In the high dose, the patient received hemodialysis every day, and in the standard dose, the patient received hemodialysis every second day. And you can see here the duration of acute kidney injury is significantly shorter in the higher dose compared to the standard dose. As well as the mortality. This is significantly reduced, 28 in the high dose versus 46 in the standard dose group. A couple of years later, 2 large randomized controlled trials were published. The first study was performed in Australia. 35 ICUs participated. They recruited more than 1,500 patients, and they compared a high versus a standard CRRT dose, and the primary outcome was a 90-day all-cause mortality. And here on the left side, you see the primary outcome. There was no difference between the high versus the standard group. And the authors also investigated different secondary outcomes, but there were no differences regarding the secondary outcomes. This is another trial which was published at the same time. This trial was performed in the US. This was the ATN trial. They recruited more than 1,100 patients, high versus standard CRRT dose, and they showed exactly the same results. No differences between the standard and the high dose regarding 60-day mortality, hospital mortality, and complete recovery at day 28. So the next question is whether we can go lower than 20 mL per kilogram per hour. And this is a retrospective study. 97 patients were included with sepsis-induced AKI, and the primary endpoint was the 20-day all-cause mortality. And this study demonstrated that if you go lower than 20 mL per kilogram per hour, the mortality increases. So an inadequate CRRT dose is associated with an increased mortality. Based on all these studies, a meta-analysis was performed. 12 trials were included, more than 5,400 patients, and high versus standard dose CRRT was investigated, and the authors conclude high-dose renal replacement therapy in AKI doesn't improve patient survival or recovery of renal function overall or in important patient subgroups. So back to the KDIGO guidelines, which were published in 2012, they recommend to deliver a KT over V of 3.9 per week for intermittent or extended renal replacement therapy. This is a 1A recommendation. And for continuous renal replacement therapy, they recommend to deliver an effluent volume of 20 to 25 mL per kilogram per hour. However, the data I showed you doesn't preclude that CRRT dose is not important. All the studies investigating the CRRT dose used a fixed CRRT dose. However, it remains elusive whether a fixed CRRT dose is adequate for critically ill patients whose clinical status may change unpredictable. And this is a precision CRRT dose delivery concept which was published by the ADKI group, and this concept says that the CRRT dose should be adapted according to the clinical status of the patient. So for example, patient A is a patient with a pneumonia and an oliguric AKI. This patient has a hypercatabolic status and the serum creatinine levels increase. So that means that we have to adjust the dose, so we have to increase the dose, and after a couple of days the patient recovers, and then we can decrease the CRRT dose. So that I can conclude, renal replacement therapy has to be started early enough to avoid complications. We shouldn't wait until the patients develop these complications because they are associated with an increased mortality. We have to identify the patient who don't spontaneously recover from AKI so that we can perform an individualized medicine, and biomarkers might help us to identify these patients. An effluent volume of 20 to 25 mL per kilogram per hour for CRRT should be chosen. Prescribed CRRT dose is dynamic and may need to be modified in response to patient factors. Thank you very much for your attention.